Good afternoon. In this session, I'm just going to report the pilot study that we did in Prince of Wales Hospital. The other co-author in this study were Professor Phil Crow, Stephanie McMillan, and Professor Nick Hawkins. First, I want to talk about biobanking. Some of you might know what it is, but in general, this is just some introduction of what is biobanking, and it is a collection and a storage of biological specimens, ideally linked to clinical information, and it is an enabler of translational research for better understanding of the disease, better treatment, and also better patient's outcome. The HSA Biobanking, which stands for Health Science Alliance Biobanking Program, was established in 2012, and it is a collaboration between University of New South Wales, Southeast Sydney LHD, and SEALS. The universal patient consent to and collection of tumor samples, blood samples, clinical information, and administrative health data like Medicare data. So what is the difference about the HSA biobanking? All patients that are having surgery for cancer, they give the opportunity to make a contribution to research. Processes for consent and collection are being integrated with routine clinical pathway, which resulting in biobanking being open to any researchers who wants to use this specimen after having appropriate approval. So this is the consent form, which I've got. We have got a booth out there, which you can have a look at it. The form looks like very similar to the actual consent form that patients they have for any surgery. And we also give them this pamphlet. It has got information about what is biobanking, what happens when they give their specimen, and it has got more information if they have more questions. So some of the questions that we have here, we'll talk about it later what they are, but it's mainly they are giving us permission to use their clinical data and their specimen, and also having access to Medicare. There are different types of tissue that we have been collecting in the last few years. Some of them are fixed tissue, fresh and frozen, and we also have got bone marrows. The tumor streams are breast, colorectal, upper GI, sarcoma, gynecology, hematology. St. George also has got peritonectomy, and urology and other general surgeries. So these are the hospitals that are involved. We have got Prince of Wales Hospital, public and private, St. George Hospital, public and private, Royal Hospital for Women, and also other hospitals. We have got the Border Medical Oncology in Albury. So most of the patients, they come from Prince of Wales Public and Royal Hospital for Women. And these numbers are increasing. This is just a percentage of what we have. Okay, now I'm going to talk about the pilot study that we did last year. Giving you some background, there's opportunities for cancer patients to provide consent to contribute to research, which is also labor intensive, inefficient, and it is costly. Patients' perspective on how they are best approached can help improve the consent process. It could also increase the value that biobanks bring to researchers and to the community. So the aim of the study was to better understand participants' view regarding the validity of consents that gained at the pre- or peri-operative periods, and to the process of recontacting them following the original consent. So the method, it was semi-structured interviews that were conducted with patients from Prince of Wales Hospital who were consented between September and November 2015. Also, we contacted patients who they had consented in July to August 2015 and had been that was prior to the development of the information sheet. And then later on, we sent them a letter inviting them to participate in the study with a provision of opt-out, which they could either by calling us, emailing us, or by returning in mail and pre-addressed stamped envelope that was provided to them. So interviews were transcribed and thematic analysis was performed in using the NVivo 10. So in total, we had 20 participants, 7 male, 13 female, and the average age was 58 years old. So these are some of the questions that we asked the patients. First question, do you remember signing the consent form for biobanking? 95% responded they clearly remember or remembered, and 1% couldn't remember. Some of the comments from participants is, I remember that I signed it. I probably signed for consent, but don't remember. That was the person who couldn't remember. I remember signing for my tissue to be removed and to be used for medical research. It was explained well enough to me, and it is selfish not to consent to biobanking. It can help others. Everybody should do it. The second question was the purpose of consenting to biobanking explained to you at the time you gave consent? So 80% they said it was explained very well or well. 1 person wasn't sure, and 3 people they said it wasn't explained very well. These are some of the comments. They said they also gave us flyer. Anything that can help doctors is good. It is for research, and I'm happy to go along. And the explanation was to my satisfaction. Question 3 was about the time of consent. We asked them, regarding the timing of being asked to consent for biobanking, do you agree that it was appropriate to be asked at the same time as you were consenting for the surgery? And the result was that 100% they said they strongly agree or agree, and they said, there are also comments that one patient said, I think people might answer this question differently. It depends if they had a good or bad results. Question 4, we asked them if they had decided not to sign the consent form for biobanking, do you think it would have affected your subsequent treatment? And 100% they said no, it wouldn't. And they also said that I don't think it would make any difference. And the last question, there was a proposal, I mean, still is alive, I presume. There's a proposal by New South Wales to make it necessary for all people who have consented for biobanking to be recontacted 1 month later to reconfirm consenting for biobanking. And whether, they want more information, and we asked the patient, how do you feel about being contacted 1 month later? So participants were less agreeable to the concept of being recontacted for validity of their consent form. Although half of the participants did see the value of being contacted, and mainly the qualitative response to this question suggested that they believed that such recontact would provide to them further useful information, especially in regard their tissue that has been taken, and they wanted to know what's happened to that. So they wouldn't think that recontacting means we just want to ask you, are you still happy to be part of the biobank, and reconfirming your consent. So some of the comments also that says here, no contact, they were the negative one, I should say. Not feeling the very best at the moment, bad time to ask me, terrible time to getting over radiotherapy. I'm really ill, it's just I have not a good day. And another person said, no, I'm really sick. I want to be helpful, but I have to prioritize my time. So this was another comment that said that I don't mind to be contacted, but I don't think it is necessary. I go along with what it is needed, but I don't think it is necessary. It was thoroughly explained by surgeons, very appropriate timing, but I don't want to talk about it after that. That would have been issue for me to be contacted for information, but it is not necessary to be contacted for reconsenting. So several patients highlighted the difficulties faced in the post-operative period by people receiving ongoing treatment for cancer, such as chemotherapy, radiotherapy, meaning that they were often ill-equipped to deal with recontacted at that time. Finally, others raised the concern that contacting them again will bring all the bad memories and difficult time that they had. Thus, it would add to their unwanted psychological burden. And it will generate anxiously related to possibility that something negative has happened to their tissue that we had taken from them and we had studied. Looking at the positive part, some of the code that I have put here, they said, I'm quite happy to be contacted. It is okay to contact patient if you have any result on the tissues that you have researched on, but not for reconsenting. That's not necessary. It is fine to be contacted for any update on the research. So, as an outcome, see that none of the patients indicated that they wanted to be contacted regarding renewing their HSA consent. They were happy to be contacted by their treating surgeon or physician, but that's mainly related to their relevant research that has been done for them. Looking at some of the limitations of the study, one limitation was that the approach in this study was to the patient who initially they have contacted, but we don't know those who they have refused to consent. So it is possible that such patients may have less positive view regarding pre or perioperative consenting. However, refusal rates are typically less than 5 to 10% in the biobank process that we have. And therefore, the issue is unlikely to have had any material influence on the undergone surgery for malignancy. So the other one was all these patients, they did go for surgery for malignancy, and we don't know what would be the result if it wasn't for cancer result, it was for just a normal patient, if they would do that. And in conclusion, the results of this qualitative study supports the current approach that we have for preoperative consenting and highlights concern raised by participants regarding the impact on their well-being of any provisions for mandatory recontact 1 or 2 months after original consent. I would like to acknowledge the contribution, the list that I have here, Professor Nick Hawkins and the investigators, SEALs, TCR staff, that some of them are here, and also staff and patients from the hospitals involved. Thank you.